Javid. Kasim's Professor of Osteoporosis and Adult Rare Bone Disease in Oxford, with research interests in epidemiology and adult metabolic bone disease, osteoporosis, vitamin D deficiency, the list goes on, Cass. And he's also active in FFN, for which I'm very grateful. So we hand over to you, Cass. Thank you very much. And please remember, put questions in the Q&A or in the chat, and then I can gather them together. But thank you very much.
Oh, thank you, Karen, and thank you, Nano-X, for sponsoring this symposium. And Angela, you've made my job so much easier by going through a lot of the information. It's a fantastic opener. Thank you. And I'm going to have to look at the New Yorker article, and my maths is not as good as yours. I can't multiply four-digit numbers in my head. I don't think I ever could, actually. So here are my disclosures, and as Karen mentioned, I'm actually now a treasurer-elect for the Fertility Fracture Network. So I'm just going to run through and sort of build on what Angela said and say, well, how do we bring this to the FLS model? Because Angela's mentioned things around fracture detection, bone density estimation, but is there more we can do? And I just thought we'd start off with, well, where are the gaps in the FLS model? Why do we even need to think about AI? And then work through the potential opportunities AI can have. A lot of these are my personal reflections, but I get the feeling this is actually going to be coming to our services sooner than we expect. So as you know, the whole point of fracture liaison services is to reduce fractures. And we do this by finding high-risk patients who are going to refracture and then giving them the right treatment so they can stay on to maximize fracture reduction. And we deliver this through the FLS model. We've got the standards for identification, investigation, treatment recommendation, monitoring. And as you know, we're pushing more and more FLSs to use key performance indicators. We don't mind which ones, but use something that you can measure your FLS against to see how well you're doing. Are you finding the expected number of patients? Are you assessing and recommending the right treatments quickly enough? And are they starting and staying on treatment? But we're all facing the same challenge. There is a mountain of fractures. It's huge, and yet we're constrained. We don't have an endless supply of staff. We have real workforce issues, and often we need to see more patients with same or fewer staff. And this is really great publication by the team from Ireland that came out earlier this year that really emphasized how much of staff time is spent with admin that could be freed if we find another way. So how could AI help? And what I'm going to do is run through the different ways that AI could help and the key steps for FLS. So I think Angela's already mentioned identification, and we're going to hear from Rachel about the use of AI for vertebral fracture identification and its practical aspects. But finding vertebral fracture for an FLS is really important, often neglected because they're hard to find, and yet we know two things about these fractures. They significantly predict hip fractures, and we've known this for decades. And also, they predict the next fracture happening soon, a sort of imminent fracture risk period. And here you can see the data from Reykjavik and fractures over 10 years. And you can see that within 2 years of a spine fracture, 50% of all the fractures of the next 10 years have already happened. And by 5 years, we've already got 80% occurring. But it's really hard to find them. They come with back pain, and usually we don't like x-raying people with back pain because the volume's too high. Sometimes we add VFA or vertebral fracture assessment to DEXA, but this is quite hard to do consistently. And then we've got issues around case finding in primary care with the work of Professor Clark from Bristol, looking at that with the Kashiba study and VFRACT. Maybe we could just look at all the radiology reports and pick out the ones with fractures, or maybe we can use other methods. But we need to do something. So this is a CT scan from one of our patients that we found. And there are 7 moderate to severe vertebral fractures. And the report says no sinister bone pathology. Wow, how many more fractures do we need before there is a serious effect on patient outcomes? And we've tried really hard in the UK, and I'd encourage you all in your countries to do this, is to audit your radiology services. We have the audit tools and templates you can use. So you can see the results of the audits in 2019 and 2022, a large number of hospitals, thousands of scans, and look at the number of vertebral fractures that are completely missed on the report. And even when vertebral fractures are listed on the report, 60 to 70% use the term vertebral fracture, but a very minority recommend further management. And as Angela mentioned now, there is a plethora of AI tools for detection. This is a recent publication using the data from Sweden, which looked at AI detection, and you can actually see where the fracture is. But AI tools for vertebral fracture identification is evolving. We're now going to look at the muscle and the BMD and demographics to even enhance our fracture prediction to another level. So while we're using AI for vertebral fracture identification, as Rachel will talk about, actually there are new tools coming out all the time, and some of them aren't even using radiological images. So actually this is using the American data set where they just use risk factors and laboratory tests to predict people with a T-score of -1. And this study from 5 years ago was quite influential because it showed that just using routine healthcare codes, importantly, could pick up the first fracture, but also the next fracture with even greater sensitivity and specificity, showing that we're really getting to a stage where we're going to be using not only the imaging, but also our electronic healthcare records to identify these patients. So that's how AI could help with FLS. We're going to hear a lot about radiological images, but don't forget there are other data sets we can use. What about investigation? Well, we're all familiar with FRACs. We've got the questions. Sometimes patients go for DEXA scans. Sometimes they have laboratory tests. We look for secondary causes, and we use this for treatment selection. And this may be because we might need to know about renal function or cardiovascular risk assessment. But how can AI influence this? Well, AI can do this in lots of ways. First of all, we've got data in different areas. We've got data in the clinical record, laboratory tests, prescribing. AI can create a summary of this, very easy to digest summary, as Angela already mentioned, and summarize large volumes of data quickly. Already in some NHS services, we have something called ambient AI. So you just have a conversation with the patient about their bone health, their risk factors, and the AI will then just summarize it for you, both for you to use, for you to send to the GP, and even a patient-friendly version. And as Angela's already mentioned, there are lots of AI tools for estimating BMD. Also, the HealthOS tool has also recently been cleared, but there's over 267 papers that include some estimate of BMD from AI tools. And so you can see how AI is already now pushing us to become much more efficient and see patients quicker. And the next phase is going to be even more exciting. An AI interviewer, the benefits are quite clear. It can happen at any time. We're not constrained to the 9 to 5. You can talk to the AI for as long as you want, as frequently as you want, in any language and any health or digital level of literacy. And this is transformative. We now have access, if we can train the AI interviewer properly and safely, an opportunity to really open AI to parts of the world where healthcare systems are very constrained. And then you could have an AI scheduler that could integrate with the patient's and caregiver's calendar. When's the best time for them to go for which lab tests and where to go for the nearest DEXA scan? And the treatment selection, we often focus, renal function, cardiovascular assessment. But what about the patient's previous treatment? Many of our patients have multiple comorbidities, and maybe the AI could summarize the GP and pharmacy data, look at their adherence pattern and say, look, for this patient, they're great. You can give them a treatment that's slightly difficult to take because they're really adherent to treatment. Or you could say, look, for this patient, they haven't adhered to any of their other treatments. You really need to think of a treatment that's more easily adhered to, such as an injectable. So you can see that AI can really, in the next generation, influence investigation. And I think it's conceivable that within I don't know how long it's moving so quickly, but you could think of an FLS chatbot doing the first level of assessment with the patients who can access it, and also involved in scheduling their DEXA and lab tests, maybe in interpreting them. So what about treatment recommendation? Well, I've already discussed how ambient AI is already summarizing medical and patient conversations to produce reports that can go to the GP and to the patient. But the real power of AI, as it gets familiar with many aspects of the patient's record, not only in healthcare, but in social media and also other aspects, is really have a deep understanding of shared decision making. Often FLSs are working under tremendous time pressures, and we all aim for shared decision making, but it's sometimes unrealistic for a patient who comes in to go through their risk factors, discuss their treatment choices, options, understand their concerns, all within 30 minutes. Sometimes the patient may not even know what they want to know. And so there's a real element here that we can have the AI help us to understand actually this patient is usually concerned about these aspects of care more than these aspects of care. And we can have a much more human-centric approach to treatment recommendations that really brings to the clinician's attention all the various potential concerns the patient has. And also the AI can help alert the patient's wider medical and social network with permission that could support the treatment decision making. The patient could then say, look, I really want my these friends and family to know about it so they can help me with my journey. I have mental health concerns. I have physical concerns, and that could be integrated with the artificial intelligence model. So you could see how there's a real opportunity for a treatment recommendation in terms of personalizing the patient report. But I think AI really comes in with the monitoring. We know through the KPI work that actually monitoring is super important. There's no real value to the patient or to the healthcare system or society if you go to all the effort of identifying, assessing, DEXA scanning, recommending treatments, if the patient doesn't start treatments or doesn't stay on the treatment. And we traditionally do this either through in some healthcare systems, they have to, for reimbursement reasons, have to see them in clinic. Often many are now switching to telephone, but even this is difficult to scale up once you get to thousands of patients a year. You can send questionnaires, but they got very poor return, or we can simply test the electronic record where they even prescribed it. And you could imagine that we could integrate adherence with medication support with an AI model. The FLSs just check, are you on medication? But they don't actually support the patient in many cases to stay on medication. Maybe they saw the FLS team for 30 minutes, then they have a phone call for 10 minutes, say 16 weeks later, and 15 minutes 1 year later. That's really not medication support for the intervening time, and we depend on primary care or other aspects to do that. And an AI support module could respond to the patient's questions at any time with expert input, integrate medication collection or maybe testing before some injectables, and also act as an alert to healthcare teams if there's an early warning that adherence is fading way before they stop the treatment, and push relevant updates so patients recycle and restart treatments when they need to. And I think it's this integration with other medical conditions that's so important. We often see the patient just as through the lens of osteoporosis and fracture reduction when they may have many other comorbidities that need to seamlessly fit in with their osteoporosis journey. So you can see now how monitoring also has the potential to be scaled up with AI. So to finish off, what about service improvement? So as many of you know, we're really focusing on this in the UK and New Zealand and in Ireland and other countries where we use patient level data to see how are all of the services behaving in terms of identification, assessment, recommendation, and monitoring. And we have, the 7 steps for quality improvement, as you can see listed there. And we have tools like fishbone and driver diagrams. And these are great. We get the team together, but they do take a lot of time and a lot of effort. So how could AI do better? Well, AI could look at not only your service, but look at comparators with other service. And it could actually generate a local service improvement report. It could flag by looking at the KPI delivery on a minute by minute, hour by hour, day by day, week by week, or month by month, early gaps and early warnings. It could look at these patterns and see if there are any learnings from other FLSs, and then recommend service change options from either small scale or large scale. And it could look at the literature and see, well, these looking at the literature both published but also in your locality, what change options are more likely to be sticky and sustainable. And this ongoing performance evaluation could then lead to very targeted feedback, either timely or in terms of content to key members of the team to improve performance. And it really offers the opportunity for a very personalized balance where they can maybe provide mentorship. So, this is how it's worked in other areas. Coaching, really helping the team members look at what they're doing in another lens to see how they can improve, as well as teaching, improving competency in other aspects. So that's me done. Obviously, I work in a very small cog in a huge team. I want to highlight the fracture prevention team in Oxford that's led by Sarah, and also the team at the Royal College of Physicians with the FLSDB. And I'll finish off with a sort of summary of kind of looking where AI could take us. And I really do think it really helps us tackle this massive sort of barrier we have. We have so many patients and we're often struggling to meet them. AI could be a way that maybe 30, 50, or even 80% of patients could be managed in a much more enriching way. And then we can flag the outlier patients or patients who can't access AI for the more traditional human FLS approach. Thank you very much.